my name's Auntie Jane, and I'd like to begin by paying my respects to all the different tribes and the traditional custodians of this land on where we are meeting upon today, and for the aunties, uncles, mums, dads, nieces, nephews, brothers and sisters, and to the traditional custodians of this land on where we are meeting upon today, for its elders past and present, and even for the self-aggressive people who passed away and who are still here today on Aboriginal land. Thank you, everybody, from Auntie Jane.
Thanks, Auntie Jane. We've actually added something into our slide now.
Oh,
So we're just going to actually
oh,
let this play for a moment. So just a minute, if everybody would just take a moment just to reflect.
How you doing, folks? Welcome to today's episode of One Mindful Minute. Now, today's topic is be proud. So we know that pride can mean a lot of things. Sometimes it can mean to hold on to certain things. It can be used in both a positive and a negative light. But today we're going to talk about being proud of you. You being an amazing soul and a gift to humanity. Having generation after generation after generation after generation of deep connection to the land, to the air, to the water, to the animals, and a deep reverence. There is no one on this earth like you. No one that can connect the way that you can connect. It has the light inside of their hearts like you have, and the ability to share that with the rest of the world. So we, as sentient beings on this earth, give you thanks for your love, your connection, for all of your ancestors and your spirits. We thank you. Have a lovely day, folks. Thank you.
there's another one.
Western Victoria Primary Health Network acknowledges the traditional owners and custodians of the land and waterways. We recognise their diversity, resilience, and the ongoing place that Aboriginal and Torres Strait Islander people hold in our communities. We pay our respects to elders both past and present and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We would like to acknowledge the lands on which we are meeting today. We also acknowledge people with lived experience and their supporters. Australia is a signature to the United Nations of Convention on the Rights of Persons with a Disability. We refer you to both Article 25, which is health. Persons with a disability have the right to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability. And Article 9, accessibility. Persons with a disability have the right to access medical facilities and emergency services on an equal basis to others in the community. This information aligns with the following: the National Standards and Quality Safe Services Standards, particularly clinical governance, partnering with consumers, comprehensive care, and communication of safety. It also partners or aligns with the Inclusive Victorian State Disability Plan 22 to 26, the Disability Inclusive Bill, and the Disability Act 2006. I'm now going to let you have a word from Laura and Jack. It's in relation to the National Roadmap, which the Primary Care Enhancement Project, which is the project we're doing called SPIDER, sits under for the first 3 years. And just a couple of stats out of this information: more than twice the rate of avoidable deaths for people with an intellectual disability, twice the rate of emergency department and hospital admissions, substantially higher rates of physical and mental health conditions, and significantly lower rates of preventative health care.
Australia's healthcare system is one of the best in the world. Most Australians consider themselves to be in good health.
But health outcomes are so much worse for people like me, living with intellectual disability.
Between 1 and 2% of people have an intellectual disability.
We experience double the avoidable deaths, worse physical and mental health,
Lower rates of preventative health like vaccinations.
many of us use multiple medications.
An Australian study found on average we die 27 years younger.
Many of us have complex health conditions that are difficult to diagnose.
And sometimes the signs of illness are not so clear.
Communication can be harder in both directions.
But we want to be healthy and
We have right to good health care.
The Spider Project. The Spider Project back in 2021, we actually started this project and we went out to the community. We would have liked to have visited the community, but we were full on into COVID at that stage. So we actually went round by teams to those that we could. And out of that, we ended up with 6 different areas that we worked on. And we called this the project itself, the project with 3 areas here that we're working to. One is workforce training and development. The second is information resources and engagement and advocacy. This is our intellectual disability, which is in the roadmap, what it actually says or stands for in this context. I won't read all of this information, but really it's those that have been diagnosed, but it also includes the groups of people in addition to people that have an established diagnosis. So people who have or are suspected to have an intellectual disability, but don't necessarily have a formal assessment, and also people with autism and or other developmental disabilities who also have an intellectual disability. So it's quite a broad definition. So who are or what is primary health care? We are referring to a bit more of a broader than we used to actually have. Instead of it just being GPs, it's GPs and doctors, clinical nurse, maternal child and health, allied health professionals, mental health, dentist and oral health professionals, and we now have definitely included pharmacists, and of course the ACCHOs and practice managers, reception and administrative staff. We also look at the interface as part of this project. So those in pathology or medical imaging, specialist, ambulance or emergency services and hospital staff. When we say we refer to them, because in all these areas, there's room for reasonable adjustment. So what your current processes are and what the touch points for you and each person within your team have, and what you could alter or adjust to actually make sure that you have inclusive practice and you're able to bring in people with an intellectual disability, whether they be verbal or non-verbal. What needs to be adjusted to actually make those adjustments? We also look at the interface with other areas as well, disability sector in particular, NDIS. When we talk about disability, everybody immediately says, oh, but people have got NDIS. NDIS is a support service. It does not make any adjustments to primary healthcare or tertiary services other than provide support to the individual person. They aren't a service, they are a support mechanism that help people access these services. So it is both primary and tertiary staff that actually need to make those adjustments, both from a policy all the way down to operational, so that we can actually make it more inclusive. Of course, people with an intellectual disability do access drugs and alcohol, almost certainly are victims of domestic violence, end up in aged care sooner or later if they live long enough to be able to do that, end up in the justice system by default, and very often child protection, both as potentially a client and or to have your child removed by child protection. So all of these areas also interface with the primary health care in one way or another. Now, some of the information that Auntie Jane in particular might share today can be a little bit upsetting and disturbing because she has had some challenges in her life. So if people feel that they'd actually like to or need to reach out for some support, please feel free to do that. So today's session is called Inclusive and Best Practice in Healthcare for People with an Intellectual Disability. This is our team. Here's Auntie Jane, who you'll hear from again, our practice facilitator, who is Sharon, myself, and then Nicole. Key learning outcomes.
Can
Yes.
I ask you, Amy Robertson, is that related to you?
No, it's not someone that's related to me, Jane, no. Not that I'm aware of. I should say not that I'm aware of. So today's learning outcomes are identify reasonable adjustments to standard practice that help to overcome barriers in health care commonly experienced by people with an intellectual disability, identify resources available to promote best practice when providing health care to support people with an intellectual disability, and identify responsibilities of healthcare services and their staff to ensure the service is accessible without discrimination in line with the United Nations Convention on the Rights of Persons with an Intellectual Disability. So in healthcare, what needs to be considered? What if the patient has an intellectual disability? What stays the same? And what needs to change? So reasonable adjustments. Reasonable adjustments are things like, do we have an inclusion policy at your service? If not, is it something that you would consider that you would need to have, not just for people with an intellectual disability, but for everybody? So it's an inclusive service. From an operational perspective, as I suggested earlier, when you and in your service and the tasks that you do, what is your tasks and your roles and what might need to be adjusted for people with an intellectual disability? If you're doing assessments, are your assessments done in easy English so that a person can understand what you're going to do? Or do you have visual aids to assist in that? They're definitely areas and things that need to be improved in this space. Accessibility and assessments. Communication also needs to be considered along with the environment. Communication in particular, if it's a person that's non-verbal, how do we make sure or understand them? So we need to understand who this person is that we're working with, what their communication response is, rather than just talking to the carer or the person that's actually supporting them on that day. We have an obligation to talk directly to that person and learn to understand and communicate with them directly rather than actually through other people that might assist them. We need to think about our own attitudes to people with an intellectual disability and behaviours. We have a GP that works along with us and does training, and he said, I've even, despite the fact having an adult son with an intellectual disability, had to actually do a check and balance for my own biases that I have learnt to have as a GP, as a professional facing, as well as looking through my son's lens. Because I guess everybody thinks because a person does have an intellectual disability, well, then they don't actually have to worry about being mindful to speak directly to them because they probably won't understand anyway. So it is doing a bit of a check and balance about your attitude. Now, I guess what is working in your system, in your world? What is not working? What are the challenges or barriers? Where are the gaps, and what are your ideas for improvement? When we did go out and ask people, we found that people had lots of great ideas and that we needed to think about how we could start to implement them. And lots of those things have been defined by people that we now work with. Now, Arnie Jane, can you help us out by giving us an example of good healthcare and what it means to you, please?
Yeah. My good healthcare is when I went to the Aboriginal Health Service going back last year, and I was my new not NDIS worker, but a worker from Winteringham came along with me. And when we went into the doctor, I explained to the doctor what was the matter with me and all this and that. And then we were in there for about 5 minutes, 7 minutes, and I was telling her about all my health problems and all that, what was going on and that. And then after that, she spikes up and says, is there anything else now? Are we finished? And when she looked at me, I go, okay. And then when we walked out of the Aboriginal Health Service, I had a good word to her and I said, please do not ever do that again. It's my appointment, not your appointment. You put the hat on for Winteringham, leave that other hat on off where you work after hours and that. And when you're with me, you put the Winteringham hat on, but you leave it up to me, I said. And ever since then, she has not spoken for me ever since because I've laid the law down.
Thanks, Jane. Now I've lost my things. Come on, back you come.
They're playing up.
No, it's me. It's just the driver, Jane. It's all right. We'll
What
get
are
there.
you
Now I've turned off the sound. I minimised it, hoping that I would be able to see, people would be able to see you as well. So now it won't let me continue to go back. Now, just a little word from Laura here.
Laura and her GP.
My old doctor, like in the past, was not clear. Really big words that I don't understand, and it all ignored me. Just focusing on my mom, not me. I was disempowered, really unhappy, and not really in the mood to talk. I told him that treat people with disability with respect, understand us, try to understand. And then things changed, things got better. Getting to know me first is very good, and I get to know them too. Every time when I go, it can run smoothly. Always say hello, greeting me, say goodbye, do checkups properly, always print out prescription correctly. He tells me things in steps what I should do teleconference on the phone, ring up saying, how are you feeling? Are you okay? Appointment, you can come in or I can call you back. Yeah, so very friendly. I think it's very nice. Both way of communication, great communication and feedback. I'm very happy to see him. Yes.
This video was created using
Now another few words from Eamon's as well.
Eamon. It is important to speak to me.
My name is Eamon. I live with my pet dog Rocco. I cannot talk, but I understand what you say. Give me time to think about the answer. I think doctors and nurses need to learn how to speak to people like me. Give me time to think. Explain what is happening. Tell me what they are going to do. Ask me before touching me. Look at me. Talk to me, not my mum or support worker. Ask me the questions. Ask what communication needs I have and what I use. Ask, do I understand what's happening? Ask me what is wrong. I am the boss of me. I am not your boy. I am 25 years old.
This video was created using funding from the Australian Government Department of Health.
Honey Jane, making appointments.
Yeah, making appointments, I need support to book the appointment. Clinic staff should understand who to contact if not me directly. Choosing a day of time that works well for the client, because you always have to ask the client what day suits them, what time suits them and all that. Having a longer appointment times, because some of them do need longer appointment times as well. They do. Seeing health professionals who already know me. A reminder about my upcoming appointment, depending on my communication needs. This may be a phone call, a text message, or a type, is it? Or what's that?
TTY, that's okay.
Yeah, sorry.
That's okay, all good. Or contact in person. We did have a scenario, I'll tell you very quickly, where we had an advocate come forward to say that one of the clinics had refused to actually ring a person to remind them about the appointment. They sent text messages only. So the actual advocate rang the clinic and said, would you mind sending either me or the person's mum a text reminder, and they flatly refused. So that's where we still have situations that where people aren't making reasonable adjustments to work because the person didn't read, so they couldn't read a text message if you sent it. So that person had missed appointments, and that appointment would have changed everything for that person. Thanks, Jane.
That's all right.
Making appointments, a patient alert can be embedded onto a clinical software to advise the support needs. You would recall Eamon's, I always get his name wrong, sorry, Eamon's, when he said that I am the boss of me, and what he was talking about is having a patient profile about that person. He had his dog, Rocco. That is one of the engagement points to actually engage with a person. So we've actually created a patient profile, which is an About Me template that you can go into on our Practice Connect page, which is down the bottom. If you look at the information, and Nicole will also pop it in the chat. And there's also a visual guide and some examples of what you might like to put in there. But we feel that that's something that you could actually have on the person's file. file, either a hard copy or an alert on your system that just pops up to say when this person rings to make an appointment or is coming to see you for something. It's just a reminder, how does this person communicate? Do I need an extra long appointment? Who do they have coming with them? Do they like to speak directly to me? How do I greet them? How do I make them welcome, and how do I give them the time that they required? But also some points of engagement so that you can actually talk and discuss their appointment directly with them. Things to consider for Kit's profile here. He's an older person that's Aboriginal. He actually speaks to communicate. He lives with his mum. He enjoys a couple of things here. He also has a history of mental health, and he's had a recent loss to his dad. Now, he might present very, very differently when he comes in. You might like to ask him if he might like to have an appointment or a discussion on his own without Sherry, his mum, because he mightn't be feeling too well, and it might be to do with grief. But often when people with an intellectual disability come in, they're overlooked for things that might be happening for them because it's just a behaviour, it's just their disability. Well, actually, no, they can be communicating something to you. So it's actually being really aware of the changes that a person might present with if you know them or understand how to best connect with them. Jake's the same. We've got a profile where this young fella is out working. He's a teenager. Very, very different for teenagers going through the adolescent years or that transition period. Lots of challenges for that person, but also identifies as an LGBTQIA+ person. So it's being mindful about how do we make sure that he is welcomed into our appointments, to make sure that he is listened to, and perhaps needs some extra time that he might want to talk to people on their own with as well, with health professionals. I'm just going to put Ryan Kelly's story up now.
Ryan's got Down syndrome, but he was born with multiple sort of medical issues. So he has a cleft palate as well, and was also born with a heart defect. So he did have 3 holes in his heart, which have been repaired. He has fluid in his ears, which means that he's sort of he was mild to moderate deaf from birth, and had issues with his vision. So he had a turn in both of his eyes and a condition called nystagmus, where his eyes wobbled as well. So yes, and then when he was 13 months old, he got diagnosed with leukemia. It's amazing how tough he is and how resilient he is, that no one looking at him today would think he's ever been through anything, let alone the number of things that he went through. So, but when he was tiny, he needed lots of blood tests, and he's always been incredibly difficult to find a vein on. And one of my earliest memories that just sticks with me 7 years later, it's so fresh in my mind, is the doctor that every time he tried to do a blood test, and Ryan had really low tone and he couldn't cry, and he would just say, "Look, it's not even hurting him. Look at this, it's not even hurting him." And as a mother, I could clearly see my newborn baby was in pain. And it was one thing to know that we had to do that test. It's entirely different to have someone presume that just because your child's got an intellectual disability that they don't feel pain. I don't think there's a high level of understanding of intellectual disability amongst medical professionals. It's often astounding, some of the misconceptions you come across. At about 5, he just gradually stopped talking, and he stopped signing, and he stopped engaging with people. Before that, he was very, very connected. It's trauma, so it's complex trauma. People with intellectual disabilities suffer a greater trauma from the same event than people without intellectual disabilities. He has less capacity to talk about what happened. And we railroaded him through all of these situations where we could have taken prevention. And I look back now and I go, gosh, why didn't we? Every procedure, he should have been pre-medicated. Like every operation that he went into, he was never pre-medicated. I mean, we had an experience last year which was really traumatic for him, and this was after I started to ask for pre-medication. So we have had 3 procedures last year. 2 of them they pre-medicated him for, and it was fantastic. He woke up the next day, it was like it never happened. This had no impact on him whatsoever. The third one, I asked 3 times for him to be pre-medicated. 3 times I was reassured that he would be. When we got to, oh, they'll do it once you get up to theatre, they'll pre-medicate him when you get there. We got to theatre. The anaesthetist looked at him and said, oh, there's nothing in his notes. No one told me he needed a pre-med. I didn't even know that I wasn't having a typical child. I just thought it was a typical 7-year-old. And instead of stopping at that point and saying, okay, well, we're just going to slow down because there's anaesthetic precautions they need to take anyway, we would just push straight through. And I'm standing there going, no, we need to pre-med. And they're like, oh, look, we've just got to go. And she was gentle putting him down. And I think she thought that was enough. But he lost a whole term at school effectively from the fallout from that. It's training around intellectual disability. It's also training about respecting the word of advocates. So if a parent is sitting there saying you need to stop, we need to slow down, then stop and slow down and listen. What happens when he's an adult and I'm not there and he's got to try and advocate for himself because he won't have that privilege. He'll be a man with an intellectual disability who has communication challenges.
Consent and decision making information should be on patient's profile. Who is the medical decision maker? And it needs to be in partnership with both the patient's medical treatment decision maker and the clinician. The partnership is reflected in the Medical Treatment Planning and Decision Making Act 2016. The 2 sets of experts that this partnership brings to medical decision making are the technical knowledge and the knowledge of the patient. Who are they? What they value and their preferences regarding medical treatment. Partnerships to achieve the best possible outcome. When the patient's medical treatment decision maker and the health professionals work in partnership, they bring together their different areas of knowledge and expertise to achieve the best possible outcomes for that person. And there's a whole list of resources here, which Nicole might pop in the chat if we ask her nicely. Arnie Jane.
Yeah. When I came in for my appointment, I needed, if the health professional is running late, clinic staff should contact me before I arrive and update me when I arrive. Clinic staff to welcome me, listen to me, and make me feel comfortable. Please greet me with a smile. If the desk is high or other barriers, please come around to talk to me. Clinic staff should talk directly to me, even when there is someone is supporting me. If the waiting room is busy, I might need a separate, I can't read the other part.
Space to wait?
Yeah, because I've got this here and covering it up.
That's okay. Like sitting in an office or a car.
Yeah, yes.
Yep.
Yeah.
Some people, particularly that might have autism, might find it easier to just sit out in the car and then wait to get called in for their appointments. That's often one of the things that either a support worker or a parent might ask for, and that's a reason to actually also ask if someone's running late for that reason, just to make sure that environmentally the person is comfortable to wait in their space rather than coming into the waiting room and either being it upsetting them personally or perhaps even upsetting others within the waiting room. This is our communication, and accessibility is everybody's business.
Did you know 1 in 7 Australians will experience communication difficulties in their lifetime? Or that 44% of Australian adults have difficulty reading and writing? People with a communication disability can find it hard to use speech or understand written information. Communication difficulties can make everyday activities like shopping and paying bills harder. Removing communication barriers makes finding your business and talking to your staff easy and welcoming for all customers, including those with communication difficulties. This is called communication access. Scope's experienced access consultants and consumer testers include people with a lived experience of communication disability. They provide invaluable insights that ensure businesses are accessible for all customers. We work with businesses and community services across different sectors, including transport, retail, utilities, finance and government. We review their communication access needs and develop customised resources and training. Our team conducts assessments and awards the internationally recognised Communication Access Symbol. When your business is accredited with the Communication Access Symbol, customers know they can trust your brand to deliver excellent, fully accessible customer service that meets a diverse range of communication needs. Wherever you are on your access and inclusion journey, ask Scope about making your customer service more communication accessible. We can work with you to design a tailored package that includes staff training, customised resources such as communication boards, and accessible written information. Join over 200 Australian brands that have been accredited with the Communication Access Symbol. Contact Scope today to see how we can help you on your journey to becoming a fully accessible business.
We've also developed a resource toolkit with relevant websites and links that we can share with you. And this includes a whole lot of clinics and resources relating to intellectual disability. We also have health pathways. It's generally mostly clinical, but if people would like access to that, we can actually provide that also. It does target a lot of the professionals that might be in the room today. Honey Jane.
Yeah. After I see the health professional, I need clinic staff to re-engage with me after my appointment too. Understanding the next steps, understanding paperwork I get, like medication, scripts, results, or other information, because they need that to be explained to them so they can understand in plain English. Understand if I have to pay bulk billed or out of pocket cost. Book my next appointment and remind me using my usual style of communication, because some people might need to speak there'll be people who can't speak and who does sign language. There'll be people who can not understand hard words and that, and they need to speak in plain English and all that, and even have pictures as well. Where a referral is required, pass on my patient profile information to the other treating specialists to alert them about my communication needs.
Yep, thanks, Honey Jane. One of the areas we're looking at is looking at pharmacists to actually put information about medication in easy English or visual. So if there's side effects, the person themselves can actually understand what those side effects might be, and if they're impacting on them, they can actually tell their supporter, particularly if it's in an urgent capacity and the medication needs to be stopped. Again, often if a person that perhaps is non-verbal or a person who has an intellectual disability and doesn't know how to communicate that, it might be misconstrued as a behaviour of concern rather than it actually being something that's happening for them physically. Often medical things are also missed as a direct consequence of that. For example, one of the scenarios that we're aware of is that a person presented at emergency services with their supporters on 3 occasions. The first 2 times they were turned away and medical staff wouldn't examine the person at all. They obviously were displaying some behaviours that potentially could have caused risk. We don't know the severity of it, but we do know the third time the person actually presented an emergency services, the person became unconscious, and it was only then that they examined the person. The person had burst appendix. So what they were trying to communicate was the extreme pain that they are in, that again wasn't seen as being that there was a physical problem, only that the person couldn't communicate what was wrong, and people didn't choose to actually examine the person. Arnie Jane.
3 key points from Arnie Jane. Number 1, talk directly to me and listen to me. Do not talk for me. Number 2, ask me questions and give me time to think and answer. Number 3, be aware of my communication and support needs and inform other clinic staff like the doctor or nurse.
Again, it's making sure if that person can talk that they're given the time to actually think about that. One of the workers that we met throughout our journey when we were actually out asking people their thoughts and what we needed to turn our attention to, one of the parents said that it took their son actually up to a minute to process information for them to be able to then tell you what their thoughts were or their views were about a particular matter. I know that I talk 100 miles an hour, and I know that being in the space that we're in as professionals can actually sway our mind because we're too busy. But I guess if you're on the receiving that, it's to put yourself in that person's shoes, that you want to be heard and listened directly to. And of course, you're the person that best knows to be able to answer those questions. And if it takes time, then people need to take the time to actually listen to what they're being told. Now, this is a word from Villamanta, Disability Rights Legal Service.
Speaking as a human rights lawyer, something that we think is really important is clarifying what the role is for any support person that comes with the patient to any appointments. Some people may potentially overstep their role and introduce themselves as, I'm here speaking on behalf of this patient, where it's really important to clarify what their role is. Is that person there to just drive the patient to the appointment? Are they there to go into the appointment with them? Are they there to take notes? What is their role? And it's really important to always go back to the patient. What do they want? What do they feel comfortable with? Do they want the support person to hear this private information, or do they want it to just be one-on-one with the doctor? And that's really important to always check in, because it's different for everybody, and sometimes understandably patients can feel a bit uncomfortable saying that in the presence of their support worker. So it's really, really important to check in and see what they feel comfortable with. Something that we always want to remind ourselves is that it's important for others not to speak on behalf of the person with the disability. One example that we've heard has happened to one of our clients is they attended an appointment with a support worker. It was a new support worker. They'd just read the client's file that day. They then went to the appointment. The support worker told the GP, this is what's been happening. The support worker didn't know the patient, but the GP didn't know that the support worker didn't know the patient, so therefore took their word essentially. And in fact, what they were working on was old information, so the GP prescribed medication that wasn't actually relevant or necessary for the patient, which doesn't really help anybody. So it's really important that you're checking in with the patient first and checking in, clarifying what the support worker, their role is, what their history is, what they actually know about the patient if they are providing that information. But support workers can also have a really important role to play. Sometimes the patient may need support from a support worker if they're living in a residential setting and they need someone else to check in to make sure they're taking their medication. So there can absolutely be a role for support workers to play. It's just really important to check in about what that role is and not having them overstep on a case-by-case basis. I think it would be great if they could have a chat to the patient themselves when they come in and ask the support worker to just step aside, and they can have that chat of, do you feel comfortable with this person coming into the appointment with you? At what point do you want them to leave or do you want them to join? And that reception staff can pass it on to the GP or to the doctor to make sure that the expectations are clear from the get-go. It absolutely adds an extra layer of complexity if it is a brand new patient that you haven't seen. So you basically go back to the default, be careful about not jumping forward of saying, well, this is someone with a disability, we want to support them, so let's skip a step and just take everything that the support worker is saying or whoever is there to support them. It's really about taking that time. It may be an extra long appointment just to start off that relationship. It may be checking in more regularly than you would with other patients, that may be getting the patient's consent to maybe call some of the other people in the patient's life to get that extra layer of history to be able to treat the patient effectively. The default and most important thing that we, even as lawyers, have is checking with our clients, your patients, about how they're feeling. And that may be, on this day, they're happy to have someone with them and someone to hear them. That may change from day to day, and they may not feel comfortable saying exactly how they feel, depending on different settings and depending on whether there are people listening to those conversations. So for us, sometimes we even need to remind ourselves that always check in with the patient to check how they are feeling, what they're comfortable with, and that may change. Even if you have been seeing a patient for 10 years and this person's always been coming in with them, maybe they don't feel comfortable with that. Maybe something happened last week and that changed. So always just keep checking in with the patient. Would very recommend that.
We are all equal before the law.
Women and girls with disabilities should have the full rights and freedoms enjoyed by everyone in the community.
As children with disabilities, we have the right to express our views on matters that affect us.
We are capable and contributing members of society.
We have the right to physical access and information access.
We have that right to life.
We have the right to be rescued in times of disaster.
We have the right to equal recognition before the law.
We have the right to justice.
We have the right to live freely in the community, to live independently and be included.
We must not be tortured, exploited, or abused.
We have the same rights as others to choose where we live and where we travel.
We have the right to access information and to opinion.
We have the right to privacy and to have intimate relationships.
Our children cannot be taken away just because of our disability.
We have the right to education, jobs, and healthcare.
We have the right to participate in cultural and public life.
Improving accessibility for people with an intellectual disability through small changes, reasonable adjustments such as supporting community members to feel safe and comfortable when accessing health services, support the rights of people with disabilities to enjoy the highest attainable standard of health and community supports, are a legal obligation to ensure healthcare is accessible to everyone without discrimination. And if you have a chance, take a moment and actually sit down and watch this SBS show, which is called What Does Australia Really Think About Disability? It is enlightening and an amazing piece of work where you'll see all different things. I would suggest you take tissues with you because you will, I promise you, laugh, cry and do everything in between. It is a really insightful piece of work because it does show you that people do make judgments without meaning to, but we do. We are certainly, we do discriminate against people with an intellectual disability. We do talk for them instead of listen to them. We do all sorts of things. We don't mean to, but again, one of the things that we often say up front, I'm too busy. If I've heard a professional say that once, I've heard it say in all aspects throughout my over 10 years work life when working in direct supports with disability services. I guess when do we get to the stage where it's actually that everybody is treated equal because because people with disabilities should have equal access, whether you can see the disability or not. And that is why often people with an intellectual disability aren't heard or seen. The disability isn't necessarily seen, the same as if it's a dual disability. That's another whole area and a discussion for another day because we've only got a short amount of time. Nicole and Auntie Jane and I would like to thank you all for coming today. We wish that we were actually with you there in person because it's so much easier to do a presentation and then have you participate as we go in that. We would ask that you actually, again, do the survey, use the QR code, to actually give some feedback to us. And we wish we had been able to give you the real version, which is about 2 hours long. So this has been a real speed through look at it, but hopefully you've gained some insight and information today. Jane, did you have anything you want to add there?
And what about, no, that's, I don't know, you know what I sent you? That wouldn't be connected, like it's not connected, but you know what I mean?
No, Jane.
You know what I sent you in the post? I'm not the post, the email.
Yes. Jane lovely sent me a text message this morning at some ridiculous hour of the morning, but that's okay. Jane she keeps different hours to the rest of us. Unless you're a nurse and you do night shift, then Jane, you'll probably see her. But Jane did send through some information about how people are actually abusing people with a disability that live in SRSs or in alternative accommodations and actually stealing their money that's been attributed through their NDIS packages, and that some of those people have now been charged for that. So Jane obviously feels that that's a really important point to bring up. So it's not that people don't need those tools and that package funding, but just that people are taking advantage of them. It's another example where when things are set up, we need to be mindful of how things are set up so that we also do the safeguarding to make sure. Did anybody in the audience like to come off mute and have ask any questions before we actually sign off at 3?
I think I don't have a question at all, Kerry, but just wanted to say thank you very much to Auntie Jane and Kerry and Nicole for the presentation. I think we've all gotten a lot out of it and will definitely prompt some good reflections for our practice going forward.
Well, thank you very much. We appreciate that. We hope so. Really, Yeah, it's really to get that conversation started, because what we're thinking of, if each person in your role, you look at what can I do to make an adjustment, even if it's the person in comms that does the web page, that actually looks at putting an audio in there, or you look at the language that you use. Language is huge because we are a society that uses either big words or jargon. If you look at how that if a person's coming to see you, you tell them what you're going to do, you have some visual aids to show them the steps. You know, I look at that when it's somebody in pathology. If it's someone in pathology, show the steps that you're going to do. You're going to put the thing on their arm. It's going to feel a bit tight. You can talk through, but some of those visual aids can be either emailed prior to the person coming and used as a desensitizing tool. And when the person comes in, that same tool's being used, whether it's to take blood or whatever it is, an X-ray. But it's all that looking at what we currently do and then what reasonable adjustments we need to make for people. So it's to invoke conversation. So I'm really glad that you feel like we've added some value added today, and we thank you very much for your time. Well, hopefully we'll see you in person one day.
Yeah,
take care, everyone.
Where is they from? Are they from Horsham or everywhere?
Horsham, I think, Auntie Jane. Horsham and around the Horsham area. Yep.
Oh, deadly.
Thank you, everyone. We'll sign off now. Bye-bye.
Thank you.